Hello everyone, my name is Dr. Shashikiran. I'm a surgical gastroenterologist with 5 years experience in the field, and I have been working with Medfin from past 2 years. So coming to the surgical management of patients with gastroesophageal reflux disease. So pre-operative preparation, nothing major thing is required. So we get a pre-anesthetic checkup, rule out any other cardiac conditions, and that the routine pre-surgical checkup that needs to be done in the patients. Coming to the surgical part, so what exactly is done in the surgery? So surgically, we try to recreate the faulty lower end of the esophagus. So we have already discussed about a valve that was present there. So it's more of like a physiological valve. So there are so many conditions which are operating at the gastroesophageal junction to keep it as a unidirectional valve. So all these mechanisms, like it could be a strengthening of the crura that is present around the gastroesophageal junction to prevent the reflux, that is one thing, and the valve itself. So these will be the components that will be taken care of while doing surgery. So we do what is known as Cruroplasty. So that is the muscle that is surrounding the gastroesophageal junction. So it might also be weakened in some patients with gastroesophageal reflux disease. So we tighten this muscle, and the second part being the improving the physiological tone of the lower esophageal sphincter. So for that condition we do what is known as fundoplication. So we wrap the stomach around the lower end of the esophagus, so that itself acts as a valve. So this is known as fundoplication. Also we have different kinds of fundoplication, so I don't want to delve into details of all these things. So just the surgical part may we improve the anatomical sphincter and also the physiological sphincter. So again, surgery can be done by an open approach or a laparoscopic approach. Nowadays no one advises open surgery for these kind of cases. It's always, most of the times it is done laparoscopically. Advantage being the incision that is required, the skin incision required is very less. It will be in mm as when compared to an open approach wherein around 10 to 15 centimeters of incision might be needed, and post-operative pain is very less. Coming to the post-operative management, most of the times we allow patients orally by the evening of the surgery. Predominantly liquids will be allowed, and patient should be good for discharge in a day or two post surgery.